Here at the Canadian Club, we have always been a forum for public figures, thought leaders, and decision makers to share their ideas and inform the most relevant and compelling conversations of our time.
We are dedicated to encouraging debate on the issues that matter to this city, this province, and this country.
The Canadian Club is one of the most important podiums anywhere in the world that a Canadian can speak to, tell Canadians what it is that they think, develop those thoughts. And so I want to thank you for that very, very much.
Please join me in thanking our esteemed panelists today.
Through our programs and events, including our youth and young leaders programs, our diversity partnerships, our joint events, and our media and social media opportunities, we offer you access to dynamic political, social, and business figures from abroad and right here at home.
The platform from which the eloquence of Canada has flowed all of that time, whether it be business, education, politics, sports, arts, and culture. If someone wants to say something to Canadians about this country and about the future of this country, this is the venue you choose.
Good afternoon, everyone. My name is Mike Kessel, and I'm a director of Canadian Club Toronto. My day job for the last 13 years is the CEO of Cleveland Clinic Canada. I would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land, which each of us call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We are grateful for the opportunity to be able to come together to learn on this land. Guests, thank you for joining us today, and thank you to our AV supplier, Van Valkenburg Communications and LiveMeeting.ca, making it possible for us to gather virtually today. Today's conversation will cover public versus private systems, health human resources, the role of primary care, and much, much more. Canada could and should be a leader in health sciences on the global stage. But how can we achieve this goal? What can Canada learn from other countries as it seeks to improve care for its citizens and enhance our healthcare system? Just before we hear from today's panel, I want to review a few housekeeping instructions. Please take a note of the following. To ask a question, click the Questions tab on the right-hand side of the video player. These will be sent to the moderator. Don't be shy. These panelists certainly are not shy. I know them. The Help button, located in the bottom right corner of the page, is for technical support. I want to take a moment to thank today's sponsors, Aird & Beerless and Deloitte, for helping to make this event possible. And thank you to our season sponsor, Canadian Bankers Association, for its continuing support. The Canadian Club is a nonprofit organization, and we have been gathering people together for 125 years. It is because of sponsors, partners, and members that we are able to do so. Thank you for your support. Now, to introduce today's speakers, just a few comments here. All of them have wonderful clinical backgrounds. They are all authentic serving leaders. Two of them are friends of mine and one a new friend. So thank you for joining us. First, I thought I'd introduce Dr. Michael Apkon, who is the president of Sand Street Advisor and the former CEO of SickKids. A personal fact about Mike, which he did not know I'd be sharing, is he is a sailor. And we have sailed, Mike and I, 24 hours together in the US one time, which resulted in some interesting stuff. So thank you, Mike, for joining. Next is Elizabeth Buller, a new friend. She is the president and CEO of St. Joseph's Health System. A personal fact about Elizabeth is she sang in a choir, and she's a heck of a karaoke singer. And lastly is Dr. Peter Pisters. Peter's probably wondering what I'm going to say about him. Peter is the president of MD Anderson Cancer Center and the former CEO of UHN. And the personal fact about Peter is he's born Canadian, but spent many years in Texas. I have shared barbecue with him, and he is a big barbecue fan and potentially a pit master. Today's discussion, you'd like that, Peter. Today's discussion will be moderated by Georgina Black, Vice Chair and Canadian Managing Partner, Government, Public Services, Health and Life Sciences for Deloitte, Canada. A tradition that our club maintains is the toast we make to our country. If you have a beverage close by, please join me in a toast to Canada. Georgina, hopefully I did okay there. Over to you.
Yeah, fantastic, Mike. Thanks for having me. Peter, Mike, and Liz, really looking forward to this conversation with you today. We had a lot of fun on our prep call. There's a lot of ground to cover. So I'm going to dig in right away, talking about the contrast between the US and Canadian healthcare systems. So both Mike and Peter, you've led organizations on both sides of the border. You've both been back in the US now since your leadership roles here in Canada, so you have some perspective. Really would like to hear from you in terms of what you see the biggest contrast differences being, and what are some practices you would encourage us here in Canada to really embrace. And Mike, I'm going to throw it to you first.
Thanks, Georgina. First, I just want to thank Mike Kessel and the Canadian Club for inviting me to participate here. And, as we look at the differences in the systems across the border, I think we should recognize that we're facing a number of universal problems, and the things that are worrying Canadians are very similar to the things that are worrying Americans and U.S. healthcare executives. But if I do look at some of the differences that I've experienced, and I'll say that I have great admiration for the Canadian system after working in both. But one thing that I've experienced in the U.S. is much more investigation of different mechanisms to create accountability around the way care is delivered. And because it's a market-driven approach to healthcare delivery, the market has been able to build in a variety of payment mechanisms that incent hospitals and physician organizations and individual physicians to be more accountable for the quality of the care that's delivered, as well as important outcomes like the total cost of medical management for a patient over the course of a year or the course of the management of their disease. A second observation is I think that the U.S. has explored much more around the power of using data to inform policy and to develop innovative approaches. We're probably a bit further down the path of implementation of things like the electronic health record, but beyond that, leveraging the data that has been collected as a result of the processes of care.
Mike, just before I turn it over to Peter, I'm wondering if there's any learning from Canada you took back with you to the US?
Well, I would say that the thing that I most admire about the Canadian system is the universality of the coverage and the fact that the disparities in healthcare may relate to things like geography and certainly differences in health literacy and things like that, but there is much greater difference in what people experience in this country depending on ability to pay. And healthcare costs in the U.S. are the #1 cause of family bankruptcies, and that's not something that Canadians experience. And so the social responsibility that goes into the approach to healthcare in Canada is something that I greatly admire.
Great. Thanks, Mike. How about you, Peter?
Thanks, Georgina. It's great to be with all of you, and a real privilege to be with the Canadian Club today. What I could say just in starting out, and I think this is a good anchoring point, is that there is no perfect national healthcare system. And it's important as a starting point that we acknowledge that, and that when we look at on evidence-based approaches where Canada and the US rank, they're near the bottom of developed nations, like at number 10 and number 11, to be specific, at least if you use Commonwealth ranking as a one metric. And so neither country has a perfect system, and there are elements of each system that are better than what you see in the other country. And there are elements of what you see in each country that are inferior to what you see in the other country. I think one of the ways in which I thought about the Canadian system fundamentally is that it's publicly funded, publicly administered private practice of medicine. And that's something that I honestly didn't understand when I came to Toronto at UHN, but I encountered in a situation where I had 1,800 individually incorporated physicians and a general belief that doctors know best and a relative lack of systemness. That contrasts to what I have in my current role, where I have 1,800 employed physicians and I can unify them around a strategy, and we can anchor them in a set of policies and procedures about how we practice medicine for the benefit of everybody. I think when we look at the US system, the fundamental flaw in the way it's designed is the linkage of healthcare insurance and therefore access to employment. And so what happens in this country is that until you get to be 65 and the government covers your healthcare through Medicare, you really are dependent on your employer. And if you happen to work for a small company that doesn't offer healthcare benefits, you don't have health insurance and you don't have access. And that translates into a lot of inequality and differences in equity, profound differences in outcomes that we see and experience across this country over time. And that fundamental flaw creates real challenges, particularly when you look at the role of academic medical centers and the social contract that exists for academic medical centers to produce talent, to produce physicians, nurses, and other licensed healthcare professionals for the benefit of society. And there's an expectation that academic medical centers will produce innovation, discovery that benefits society in material ways. And how that's financed in each country is very different. I think the fundamental thing that I experienced that I really appreciate is about the Canadian system, as Mike described, is the universality of access, where access to outstanding healthcare is a function of residency, not a function of who your employer is. And that's the case in most other developed countries, except for the United States, which has this fundamental flaw in the way the system is designed and operated.
Yeah, thank you, Peter. There's a couple of threads we'll pull on in just a moment. Liz, I'd like to give you an opportunity to share your reflections. I don't think Mike Kessel mentioned that you started your career out as a nurse, which is important to highlight. And of course, your leadership roles in BC and Ontario running large complex health systems. So from your perspective, what resonates with you about what Mike and Peter shared, and maybe what would you like to challenge?
Thanks, Georgina. And again, also thank Mike Kessel and the Canadian Club for inviting me here today. And great to be here with Peter and Mike, who I worked with while they were here in Canada. So great opportunity. I would say my initial thoughts is we're actually more alike than we're not alike. We've migrated to much more similar systems than not, because even in our Canadian system where we have universality, we still have limited access. We don't have all of the things that people need to get to the care for many reasons: financial, health, human resources, infrastructure, whatever they may be. So I think what I think of when I consider our systems and comparing not just to the US, but all of the OECD or the Commonwealth partners, that we need to think about less about what we do better than each other, but what we're actually doing well together and how we can bring those shared learnings across our systems, and not be saying, well, we're better than the US in this, we're better than Australia in this, because it actually sets us up for not progressing in advancing both access and our quality of care for for patients, but also improving the use of our resources as well that we have, because we set ourselves up to just be thinking about how do we compare ourselves as being better versus how do we say the US is doing this really well, we're doing this really well, Australia is doing this really well, and we can optimize all of those versus being so competitive.
Yeah, it's a great point, Liz, because it really stifles curiosity then when you make assumptions about, well, that's a bad system when there are really great practices that we could learn from the US and bring to Canada. And nice to hear both Mike and Peter actually identify some practices from Canada that you've respect and perhaps in your way are bringing back into the United States. Peter, you started to talk about the private system, and so I'm going to move it into the private versus public. And I hate to frame it that way because this debate in Canada is emerging. And my view is that private versus public actually isn't the right debate. The reality is, as you pointed out, that over 30% of our care that's provided is provided by private providers in a public payer model. So we need to shift out of the binary yes or no to like what's possible. And so I'm really curious to understand from your perspective, what, if any, you would like to see as the role for the private sector in Canada. And let me just build on this a bit. Both of you have been out of the country for a while, but we're starting to see an increase in private surgery centers to deal with some of the backlog that's occurred as a result of the pandemic. And then we're also seeing incredible innovations and services starting to be provided by, telcos have been around for a while, tech companies are entering into space, retailers are expanding their role. And so thinking about that public-private ecosystem, it's a lot of a bigger system than just, private physicians and maybe private surgery centers. So would like your views on that, Peter.
Sure. Maybe I can start and then Mike can add a little bit. I think the first thing to point out is to really understand what is meant by private in the United States. And there's definitely a misconception in Canada that when you have private medicine in the United States, private institutions, that shareholders are the beneficiaries of that. Most private institutions are mission-based nonprofit institutions, including the one I lead right now. And we provide millions, hundreds of millions, $330 million of uncompensated care as part of our mission at MD Anderson. And so although some people view us as private, that really is not designed to create shareholder value. It's to create societal value. And there's an obligation that we have as a mission-based nonprofit institution to provide a certain volume of uncompensated care and to report that to the Internal Revenue Service in order to be able to maintain our nonprofit status. Now, there are for-profit operators in the United States, like Hospital Corporation of America or Tenet Healthcare as two examples. They do have shareholders and they do operate hospitals. So that creates a degree of confusion, I think, among Canadians who assume that every private institution in the United States must be benefiting shareholders. So it's really important to understand that distinction at the very beginning. The other point I would make is that when we look at private healthcare in other countries, we see higher performing international systems where they do have a mixed public-private system. And the things you have to think about there are the alignment of incentives, and you have to create a framework that ensures that the best providers don't leave the public system and go to the private system. And how do you maintain quality in both systems? Realizing that taxpayers probably cannot support the healthcare needs of the entire population over time, and that by distributing the economic stress associated with managing the healthcare needs of the population between a group of individuals who are in both systems, including physicians and other licensed healthcare professionals who move back and forth between the public and the private system, is the direction, I think, that allows for more rational use of resources over time. To the extent that we maintain a commitment to exclusively publicly funded and publicly administered systems, there's going to be a burden placed on taxpayers over time. And there are going to be things like wait lists that result as out of the reality that you're going to have to ration services in order to keep costs within a specific envelope.
Liz, I'm going to come to you next. You and I have had this discussion a number of times, and I think you've got an interesting way to think about this discussion that often happens in Canada, public versus private.
Thanks, Georgina. I would agree with a lot of what Peter said, and in particular, having worked in the US too, that understanding there was this whole for-profit shareholder dispersion that isn't exactly factual. But here, I think as you mentioned, Georgina and Peter as well, we have over 30% of what we spend is private. People are paying for that. And our public system is selective. So we don't pay for things that we tend to be more at the reactive end, and we have to shift back more to the proactive or early end of care. So where we do great in our public sector and paying for publicly is in more acute care, some for sure primary care of initial family practice visits and that kind of thing if you can get it. But a lot of things like pharmaceuticals, like vision care, like mental health care, a whole bunch of our health and wellness is not covered by our public healthcare system. And those are the things that actually lead us to spending huge amounts of costs at the end of what we do pay for publicly. So, and as Peter mentioned, our physicians are all private care practitioners predominantly. And we need to be rethinking this great model that we had for our Canadian healthcare system, but we can't remain static of what it was in the 60s. It has to advance to where we are in 2023 and see what we've learned, in particular through our pandemic here in Canada, where we were able to partner with people a whole lot, much more collaboratively, less competitively, to make sure all benefit. And we can make sure we take advantage of the expertise from our private care sector experts and collaborate with our public care to advance all of what we have and have more to invest upstream. If we can invest more downstream, partnering to provide much more primary care and much more focus on our social determinants of health around housing and prevention, then we will be able to do more with the funds we're already investing. We can't keep increasing the funds that we have. We know we're in the billions of dollars, over 60% of what we spend, taking from education and social services and other areas. So we do need to revisit this, and we shouldn't be afraid of it. I think what we need to do is say we're all in this together, and it not be, to Peter's point about shareholders. That's the rhetoric that gets mixed out there versus creating collaborative partnerships.
Yeah, you brought up a couple of key points there, and I just want to amplify a message here from one of our guests in the audience who said it's interesting that we're talking about the Canadian system as universal, because we do talk about it as being a universal healthcare, but the reality is it isn't compared to some other jurisdictions. And medication, dental, physio, mental health, it's a long list of things that are not provided that would be considered healthcare in other countries. Mike, I know that you have a keen interest in data and technology, that you've done work with the private sector in the past. Would really like to hear from you in terms of what you see as, the role or not of the private sector in healthcare, and you can speak to the US or guidance for Canada.
I think Peter's observation about the hybrid systems typically outperforming those systems that are purely government funded, I think is an important one. Canada may be one of the few countries where, at least for what it covers, and I recognize the audience member's point about it doesn't cover everything, but for at least what it covers, it is almost totally publicly funded. And as we look at a private system, it will be important to sort through what's the intent. Is the intent to bring in private money into the healthcare system and to segment the marketplace according to who can afford to buy services on the private system versus who will be required to use the public system? Is it to bring in private capital to build facilities that the government can't fund, like ambulatory surgery centers, and to allow a system where those investors can get a return on that capital? Or is it to motivate other actors to join the broader public sector and deliver services that are publicly funded? And when you look at what people are talking about in the private system, it sort of covers that whole roadmap. But how you build the market, how you build the rules of the game, the rules of the road for private actors will have a significant impact on what the unintended consequences are to the public system. And I'd say these hybrid systems in the UK is a very good example, where the national health system has operated for a long time with a side-by-side public and private system. And in fact, about 10 years ago, I was involved in an educational effort where US healthcare executives were helping British health system executives learn how to create a more competitive marketplace. And now you have within British hospitals side-by-side public and private systems that has now, 30 years later, since that hybrid experiment began, or maybe 40 years later, is really leading to a significant deterioration in the publicly funded part of the system, where providers are exiting the publicly funded system for more lucrative reimbursement on the private side. And in fact, even within hospitals, hospital administrators are shunting patients that have the ability to pay from the publicly funded system to the privately funded system, and is reaching a problem there of probably pretty close to crisis proportions in some jurisdictions. So, I would look at these hybrid systems as a meta-stable system. One advantage, though, of the hybrid system is the private actors can be more nimble and more experimenting than governments often can be. And there may be a greater ability to innovate and to build care models that come closer to capturing the spirit of what Peter spoke about in his opening remarks, of a more integrated approach to healthcare that could provide an end-to-end experience for people that are living with a variety of conditions or recovering from a variety of illnesses. Government has a hard time in most jurisdictions being nimble enough to respond to ongoing need in ways that can the governments can be good at piloting things, but not that great at spreading things, whereas the private sector is much better, I think, at testing and spreading those concepts that really have an impact and make sense within the marketplace.
Just going to open it up to Peter and Liz to see if there's anything that sparked further ideas for you on this topic of public versus private in Canada. Peter?
Yeah, I mean, this is an excellent discussion, and a lot of great ideas are coming out in the conversation. I think one of the things that we encountered, I think when I was there in the Canadian system, is a general sense of complacency in the population. And now maybe there's a greater burning platform now in the sort of Ford era than there was back then. But I think if you survey the population, generally speaking, most Canadians are satisfied with their healthcare. I think they generally know it's maybe not best in the world. Otherwise, their elected officials would be telling them that repeatedly. But if you ask them to rank, where does Canada fit in international rankings? They would probably say we're in the medal round. I don't think we're gold, because my premier would be telling me that repeatedly. But we're probably silver or bronze. And it's shocking to them when they actually see where they are. And the complacency really should be replaced with a sense of urgency over time, or with an understanding, and this is true for both countries, that what we have is a very evolved sick care system, but not a healthcare system. And that we have to pivot gradually over time to different ways of managing chronic diseases and different strategies to ensure that prevention can be a bigger part of the effort in both countries.
I think, Peter, if you were to come to Canada in the next few weeks, you would feel a different vibe here from the public about the healthcare system, as well as from providers who have been very loud about this. It's very fragile at the moment and under considerable strain. So the dialogue's quite different. Liz, maybe you could comment on that as well, and then anything else you'd like to highlight with the private versus public discussion.
Sure. I would agree with Peter to a degree on the complacency, although also agree with Georgina that it's been, I would say, pre-pandemic was maybe a festering wound, and now it's exploded post-pandemic, and the complacency is a little bit less. Although I also think some of it is still based on, we have a lot of media and who people speak to, and so we haven't figured out the right balance of how we speak about that complacency. Whether it's, we know we get great care when we have urgent issues, it's some of the other things that we're a little bit more complacent about. And I think, Georgina, you were involved in the paper around Let's Take Back Healthcare, where it said, government and policymakers, they don't own our healthcare system, they're stewards of it. But we as citizens have actually allowed that to be, have lived the reverse. And I think we're starting to take that back. And that's really important that we do that and have a much greater voice and expectations, and start to have larger discussions around what are those expectations? What can we do? What can we support? What should we be supporting in our healthcare funding versus not supporting, and just redesigning that system of our very, very traditional complacent expectations of our system, and being very passive receivers. With private public, I think we just have to go there. I don't think we have the answers. It's about the how. It doesn't have to be about for-profit. It doesn't have to be shareholders. It's about how do we really take advantage of each other's expertise and build incredible systems, opportunities, innovation that actually moves to action. We're great innovators, but because we don't have resources, we can't get them to action, or action as quickly as they should be, and working to improve outcomes. So I don't think that's an either or discussion. I think it really is a how discussion. And again, going back to what we mentioned earlier, we're already there. We have a public-private partnership. We just have to speak about it more and talk about what parts of it work really well. What do we want to keep? What do we want to redesign? What do we need to add? And what do we need to stop doing? Because some of it isn't good, for sure. And it's because we don't talk about it and we don't really put it out there. Here are all the pieces of our system that put together our Canadian healthcare system. We truly, I come from a long immigrant family, long family of healthcare people, who wouldn't challenge the healthcare system, that whatever the doctor says goes, whatever the hospital says goes. And they have but when they really need some things like dental care or pharmaceuticals and all of that, they really didn't understand, older generation, that all those things aren't covered. And that is a bit of private. That's part of our private care. And unless you have good healthcare insurance systems with whom you work, healthcare providers, there's a whole lot of stuff that isn't provided in our Canadian system that would keep us healthier as well, and people out of hospital and people at home a whole lot longer. So we do need to look at how we can do this in a collaborative way with private investors and reinvesting. We can set up how we do this, but we can't avoid not having the discussion, and we have to stop the binary discussion, as you call it, Georgina.
There's a comment here from someone in the audience that says, patient demand and technological innovation in hybrid is going to drive us towards this model in Canada, whether the government wants it or not. And certainly from our work, we would see that businesses see this as really important for the prosperity of the country. And as we wrote in a paper about taking back healthcare, it's time for citizens not to be complacent about it. So this is one of those things where, incredible startup companies, I think about Maple, the virtual health company. It's doing very well, and that's one of hundreds really in this country that are starting to get traction. So I guess what we'll have to see is whether we create the conditions for this partnership to thrive, so that we can provide better care. And Peter, you earlier talked about the cost of healthcare, and I'll come back to that in a moment, because I want to challenge all of us to think about healthcare as an investment. Does that get us to a different place? But I'd be remiss having all of you leaders together if I didn't bring up one of the burning issues around the world, but certainly here in Canada, and I know in the US, and that is the shortage of health and social care, human resource workers. And a lot of factors, we knew this was coming. World Health Organization published this report that there'd be a shortage of 18 million workers by 2030. Perhaps this was accelerated by the pandemic. The systems are really struggling. My question to you is, are we solving this problem in the right way? So arguably, we see a lot of organizations just trying to get more bodies to replace bodies. And well, those bodies just aren't there. And in other industries, we're seeing organizations embrace artificial intelligence, robot, all sorts of technological innovations to augment humans. So perhaps a bit of a leading question, but Mike, I'll start with you on this one. Are we solving this problem in the right way? You're on mute.
I'm not sure if we're solving
once.
the problem in the right way, but I would say first, it is a universal problem. And there are hospitals in the US that are closing simply because they cannot afford to put a staffing model together that works for them anymore. What I think we learned a lot during the heat of the COVID pandemic, though, about ways to redistribute the responsibilities for care in different ways, and the ability to upskill a variety of caregivers with the appropriate supervision that could be provided through a combination of in-person and virtual. We haven't really, I don't think, in any jurisdiction taken the learnings that we should be taking from that to think about different kinds of care giving models. Primary care is a major challenge in most jurisdictions these days, but it's still a model that is built very heavily around an individual physician's practice, as opposed to using a physician to be able to supervise or collaborate with other kinds of caregivers, nurses, advanced practice nurses, physician assistants, paramedics, which can create models of care that can be distributed geographically, even to the point of right into the home. And we had the experience when I was with my former institution at Tufts Medical Center of initiating a strategic partnership with a company that was able to provide acute care hospital substitution in the home, with paramedics supervised through telemedicine linked to a command center with physicians and nurses. And it was quite an effective model for decanting the hospital, for avoiding hospitalization altogether for some patients. Models like that, as well as models that make better use of people with a variety of educational experiences and skill sets, I think have great potential, especially when augmented with the technology. The technology itself, I don't see as a solution. I think technology that enables people to do things more efficiently or more effectively than they otherwise could have makes a lot of sense to me. I think we're a long way off from replacing altogether caregivers, with AI and that kind of thing.
Peter, are you seeing anything that's working well in the US with respect to solving this problem?
Well, I think Mike makes excellent points in that we have to look at the work stream of clinical care and deconstruct it and then reallocate it in different ways. I think that, as it relates to licensed healthcare professionals, immigration has got to be part of the solution. And Canada has far more advanced thinking on this right now than the United States does. It's important as it relates to nursing in particular, where some, but not all of the shortages confined at the moment, to recognize that the nursing workforce is global and it is highly economically sensitive. And so what you see on a global scale is nurses from the third world moving to the second world and nurses from the second world moving to the first world. That's something, of course, that we experience in Canada and we see throughout the United States with a high reliance on nurses from the Philippines, from Jamaica, and from a variety of other countries over time. So a strategic approach to immigration and then deconstructing the work is very important. What I saw in Canada, though, to come back to a point I made earlier, and is to really understand the limitations associated with private practice of medicine. And that what you see in Canada, and I'm using old figures right now, Liz could probably give the more accurate figures, but when I was there at UHN not so long ago, the provincial healthcare budget was about 52 billion Canadian dollars, and around 12 billion of that was for physician payments. And so what we were saying as a society is that one class of licensed professionals deserves 20% of the budget. That decision and the function of the OMA as a physicians union advocating for the economic interests of one group over time really created a lot of limitations. So if you see what we refer to in the United States as advanced practice providers like nurse practitioners and physician's assistants who come in at a different price point can do probably 90% of the work of a physician, but can't be deployed at scale in Ontario because of the OMA and the fact that they put the economic interests of Ontario physicians above the needs of the population that they serve. That's a reality that we experienced over time. That's just one example of work that could be reallocated, but the barriers associated with private practice of medicine that prevent it.
Liz, I'm going to give you a chance to respond to anything that Peter said, but then I want to pose a different question to you.
I would say to Peter, I think we're seeing slight movement in that area. I don't disagree at all, but we are seeing some movement and progression in that area to more looking at, in fact, our government just announced a new budget investing in funds for more nurse practitioners, physician assistants, looking at who else can do this work, investment in our pharmaceutical industry, which we've traditionally given to just physicians, but also not just physicians, work we've traditionally given to nurses as well. We need to be looking at all of the fields and how we've defined what that work is, because we do need to look at new providers. We're not going to have new physicians, even if you give them the best fee for service and don't change the schedule to fill all the holes. This year, unprecedented, the physician matching program, almost 300 empty spaces in primary care that haven't matched yet for family practice physicians. Looking at just, work from Mark Britnell out of the UK, some research around 154,000 empty nursing positions projected to be over 500,000 in the next 10 years. We can't be replacing the same providers. We actually have to think of all of our providers a little bit differently, but our funding model for sure with the our physicians has to change. And I think a lot of our physicians want that as well. Sure, many like the fee for service model. We're not going to take that away, but I think a lot of people are really looking at much more looking at models in the US. How do we have employment models that are more, guaranteed income based, that kind of thing, like BC is starting to do as well with family practice physicians. A lot of physicians don't want to work independently, and a lot of care providers don't, nurses, allied health, et cetera. We do have to move to team-based models of care. And that way we can actually have the appropriate level of care in these team-based models. We have to invest in these a whole lot more and a whole lot more purposefully, because we can invest, our government again has invested in new nursing seats, new allied health professionals, new medical trainee seats. It doesn't matter. I came from a family right from great grandmothers to me and everybody in between of nursing. And I can tell you, not one of my cousins, not my daughters, nobody is going into nursing. So a whole generations of family, not a single, and that's so much more going out there. And I think the same, probably Peter and Michael, you could talk to that from the physician aspect and or physicians who are leaving the field too, after all that investment. So we do have to rethink, what are all these providers' roles? What do physicians do? What do nurses do, et cetera? So,
Liz, I just want to pick up on that because there's been some research recently that shows that over 6 million, I think it's 6.6 million Canadians are without primary care right now. Peter, further adding to the agitation that exists in the country right now. So you've talked a bit about primary care models, homes. Can you bring that to life for us, Liz? And then I'm going to pivot to technology and data. And then I've got a big question around Canada's competitiveness, if I can squeeze all that in the next 7 minutes.
Well, I'll be brief. I just think we have to be careful how we define primary care. Traditionally, we think of primary care as physicians, primary care physicians, but actually primary care is the whole bucket of providers who help wrap themselves around patients and families. And I think Ontario actually has done a great job with our community health centers and with our family health teams, and the government has recently invested in expanding those. We have to do more. It really is primary care is the wraparound, and it has to include the whole social determinants of health as well. So our public health and our social providers around housing and food insecurity, all of those things. When we think of primary care, we have to shift our own paradigm of thinking of primary care as just primary care physicians, and really invest a whole lot more in those wraparounds and bringing those and all our community agencies together. We have many amazing parts and systems in Ontario here, just speaking here and across Canada, but they're still very siloed. So we talk a lot about integrated care, but we actually have to not feel a threat about integrating and integrate a whole lot more purposefully.
We could have a whole session just on addressing the social determinants of health in a different way. And I know there's learnings from the US on that as well. Mike, I do want to ask you a question about technology and data, because that's sort of an area where you spend a lot of time thinking. I'd like your sort of, observations in terms of US that we could learn.
I want to kind of tie that to some comments related to Liz's remarks. As we think about primary care versus integrated care, we should recognize about 20% of the population is responsible for about 80% of the healthcare expenditures. And these are patients, these are people, we're all patients at one level or another. These are people that live with conditions, generally lifelong or for extended periods of time, often many conditions simultaneously. And the issue in having them be able to live their best life is really around the coordination of care across a spectrum, from an initial primary care provider to people involved in the rehab space, to specialists, to hospital-based services. Where technology, I think, can be especially valuable is bridging those different types of care providers, most of who do not work under one governing body. So one of the biggest challenges is we need to be able to coordinate care longitudinally across a broadly distributed network where individual providers share many patients, have many patients. They only share very few of those patients with the next provider next door that they've got to provide some level of coordination with. Where I think the technology can come into play is to be able to bridge the information gap and have information move more seamlessly, and to move in a way that makes it easier to draw insight about what actions have to be taken at that point in time. And I'm not talking simply about decision support so much as providing the information that's necessary for a caregiver, whether that's a nurse or a physician or a rehab specialist or a mental health provider, to understand what is happening in that patient's course of care and what interventions might be helpful and what people like the person in front of them might best respond to. And I do think that there are that's an information sharing and an information management and an insight derivation problem that can really only be met with advanced technology. And that to me is sort of the next phase, if you think about kind of where we're going from the initial adoption of technology like electronic health records, which now is pretty much universal across the developed healthcare world, to really being able to make use of the fact that we now have a vast information collection about the people that we are caring for, but are not really leveraging that in the way that would have the most effective or most impactful benefit.
Thanks for that. want to bring one final question forward, and I'm going to link it back to Mike Kessel's opening remarks, which was really, is it possible for Canada to be globally competitive with health and life sciences? I'm adding the life sciences piece. And, I find in this country, we talk about healthcare as a cost rather than an investment. And really, is there an opportunity to reframe how we think about the health and life sciences industries in this country to put Canada on the map? And perhaps, Peter, you pointed out that we're second to last on the OECD ranking. Perhaps we could move the dial in that way and make a contribution to the economy and society and the health of the population. So my final question to each of you is, what are your thoughts on that? Is it possible? Peter, I'll start with you.
It's definitely possible. Certainly what I experienced, and I know Mike did too, when we were in Toronto, is unbelievable caliber of science and discovery that's present in institutions like SickKids, UHN, or the University of Toronto as local examples in Toronto. And it's really being able to translate that science and accelerate discovery from really from the bench to the bedside. That really is the opportunity. And I think Canada can definitely be a world leader in that regard. One of the fundamental differences that I experienced really is the government support at the federal level for innovation and discovery. And this ends up being very, very important difference that I see between the two countries, because when you look at the degree of federal support for the infrastructure of research, the indirect costs of research, it's quite meager compared to other developed countries. And that really constrains the ability to innovate and discover. In the United States, for many reasons, I go back to the Second World War, it was recognized that higher education, universities in general, needed to be part of an innovation economy, and that the US almost lost the Second World War if it wasn't for science. And when they went to the university community in the late 40s and 50s, and they said, we need you to do research, the response was, we need money to do that. And that created a process for indirect cost support for research intensive organizations like universities over time. At MD Anderson, we have a negotiated indirect cost rate with the federal government to cover the cost of buildings and infrastructure to do research. In Canada, there isn't that degree of federal support for innovation and discovery, and they amazingly rely on philanthropic support to close the gaps that exist over time. And there's just a limited ability of philanthropic support to bootstrap things that in other developed countries is supported by the federal government. And so understanding the role of the federal government in supporting an economy of innovation and discovery is very, very important. It's one of the reasons that you see vibrant life sciences communities in many jurisdictions in the United States. This is what's driving it.
Thank you. Very quickly, Liz, Mike, is it possible? Liz?
I would say it has to be possible, and it is possible. I would agree with Peter's comments. I would say our federal government, with the nudging of our provincial premiers, is starting to move along, but we have a long way to go. I would say one of our biggest challenges, though, is we have to adopt faster. It's not that we don't have innovation, we don't have the ideas, we just change weary isn't a language that we can use in our healthcare world. We have a responsibility. We're entrusted by our public to adapt much more quickly. So while those things are going on, and really do recognize everything Peter said as some of our challenges that are advancing slowly, we have to advance and adopt much more quickly, both in moving some of those. And we showed we could do it during the pandemic. We demonstrated we can, and we need to not lose that. That's momentum and speed. And yes, we should, and we can, and we will be.
Great. I love these encouragements. Mike, 10 seconds for us, please.
Sure. It has to be possible. The quality of education, the research at the bedside, the research in the laboratories and the care at the bedside is really second to none. It's top tier across the world. And there's every opportunity to turn that into a national treasure.
I love hosting a panel where we end on an optimistic note as it relates to healthcare in Canada. Thank you, Mike. Let me pass it back to you.
Yeah, thanks all, Michael, Elizabeth, Peter, and Georgina. thanks for taking the time to join us today. It's while there's been a lot of work that can be done to improve our healthcare system in our countries, I'm encouraged knowing that we have passionate, smart folks, leaders like all of you to help drive this change. And hopefully we also learned that one is a sailor, one is a barbecuer, and one is a singer, which is also highly valuable information, I believe. You would get a kick out of you folks for that. But as a reminder, okay, there's 1 minute left. Canadian Club's vision is to be the podium of choice for relevant and provocative conversations, connecting the business community and promoting an inclusive and prosperous Canada. We aim to achieve this vision at every event, and today was no exception. Thank you so much for being a part of it, and thank you again to Aird and Beerless and Deloitte for your support. And to all of you, I think close to 500 are folks that joined, thanks for spending your lunch hour with us today. Please stay healthy and safe. And we stuck to an hour, so that is wonderful. Take care.